a negative node. Is this of any meaning to you personally? And does this data, or does this meaning, does this justify a complete lymph node dissection with all comorbidity? Yes or no? You have to answer it by yourself. Now, what about diagnosis? And this concludes my talk, and I will not be over time this time. Yeah? Diagnostic lymph node dissection. Why? Because, as we already heard, some melanocytic tumors are difficult to diagnose. Schizoid tumors, we talked about that a lot, like this one. And the pathologist might answer, I don't know, or schizoid tumor of uncertain malignant potential, or melanocytic tumor of uncertain malignant potential. And the question is what to do. Is it of benefit for the patient and for you to do a positive, sentinel node biopsy to find out if this is malignant or benign? This is what I call diagnostic lymph node dissection, to make a better diagnosis by doing a sentinel node biopsy. You are confronted with a schizoid tumor and you want to know whether it is benign or malignant. This is the concept. And I skipped that because you know the theory behind that is if there are melanoma cells in the sentinel node, then the original lesion should be a melanoma. This sounds at least theoretically logical, but is this really true? First of all, only those with positive sentinel nodes will benefit under parenthesis or under in brackets, because only those with positive nodes, they will upgrade it to melanoma, and those with negative nodes, you still don't know was it a melanoma or not, because if there is no metastasis, no micrometastasis in the sentinel node, you don't know whether it's benign or malignant. It could still be malignant without micrometastasis. Now the critical question is not this. The critical question is, if there are melanocytes in the sentinel lymph node, does it really mean that the original lesion is malignant? Now what you see here are melanocytes in lymph nodes, although these lymph nodes are not invaded by a melanoma. You can see here melanocytes in the capsule of a lymph node. This is a nevus in the capsule of a node, of a sentinel node. It's not malignant. You can see here, this is a nodal melanocytic nevus, and these are not so rare. You can see here nodal nevus within a fibrous trabeculum. You can see here melanocytes in a lymph node that is just a nevus, not a melanoma. And you can see here even melanocytes in the stroma of a lymph node, although it's just a nevus. It's not a melanoma. So there may be melanocytes in a lymph node, although it's not metastatic disease. Now, there are again some rules to differentiate nevi, nodal nevi, from metastatic melanoma, but you can see again, this is highly subjective. And if you have the question benign or malignant, you again have to rely on subjective, highly subjective data, and it's not sure whether you can truly differentiate between nodal metastasis or nodal melanocytes from a nevus. For example, this is a lymph node from a patient with breast cancer. They also do sentinel node biopsies in breast cancers, not to find melanocytes, of course, there to find malignant carcinoma cells of the breast tumor. But what you see here, you can see here S100 positive melanocytes in this sentinel node from breast carcinoma. Now, if this breast carcinoma was not a breast carcinoma, but a schizoid tumor, how would these melanocytes be interpreted? As metastasis? Although, obviously, it's just a nevus in the lymph node. Difficult, isn't it? And it does not resolve anything. And here is the percentage of patients with sentinel node lymph node biopsy with ambiguous schizoid tumors, and you can see here the percentage of micro so-called metastases in these patients is very high, 50%, much higher than you expect in normal melanomas. This is unusual, maybe because some of them just have melanocytes from a nevus in their lymph nodes and not melanoma cells. What I want to say, in most cases, the diagnostic uncertainty is not resolved. It is even increased if you do a sentinel node biopsy for diagnostic reasons. So questions and answers, and these are of course my answers. I only can give you my opinion. You can have other opinions, but if you have other opinions, you have to come with arguments, not just with an opinion. I think I give you the arguments, and the questions and answers are, what do I do? What would I recommend? Which is completely different from guidelines, I know. For therapeutic reasons, sentinel node biopsy, no, because there is no therapeutic benefit. For prognostic reasons, you may do it. Yes, no, maybe, but you have to discuss it with the patient. If he really wants to go into this only to know that he has a 30% higher chance of dying within 10 years, whatever this means. And for diagnostic reasons, I never recommend sentinel node biopsy to resolve an ambiguous melanocytic case. I do not recommend that. And finally, again, my last slide. I hope you've learned something, and thank you for your attention.